Welcome to Critical Care Simplified. In this lesson, we're building advanced physical assessment skills for the ICU, so you can recognize subtle deterioration earlier, connect findings faster, and advocate confidently for your patient. In the ICU, deterioration rarely announces itself all at once. It often begins with something small, a new confusion, a narrowing pulse pressure, a rising oxygen requirement, a change in pupil response, or skin that suddenly looks cool and mottled. Advanced assessment is the skill of noticing those early clues, then connecting them before the patient crashes. Basic assessment asks, what do I see right now? Advanced assessment asks, what pattern is forming? What does it mean? And what should happen next? A strong ICU assessment starts with structure. Head-to-toe assessment helps you avoid missing a body system. The ABCDE approach helps you prioritize airway, breathing, circulation, disability, and exposure when time is limited. Focused assessments let you go deeper into the system most at risk, neuro, cardiac, respiratory, or another priority area. But advanced practice adds another layer. You are not just collecting findings, you are integrating monitor data, invasive lines, waveforms, labs, physical signs, baseline history, and family input. You are reassessing dynamically because critically ill patients change quickly. And even in a high-tech ICU, patient-centered care still matters. Baseline function, values, communication limits, cultural considerations, and family observations can all change how you interpret the bedside picture. Neurological deterioration can be subtle and life-threatening. In critical care, a sudden drop in responsiveness, new pupil changes, unilateral weakness, seizures, or loss of protective reflexes should immediately raise concern. Use structured tools like the Glasgow Coma Scale, but remember its limits in intubated or deeply sedated patients. The 4 score can be especially helpful because it includes eye response, motor response, brainstem reflexes, and respiratory pattern. Screen for delirium with tools such as CAM ICU and always interpret findings in context, sedation, analgesia, paralytics, baseline deficits, sepsis, hypoxia, and metabolic derangements can all affect mental status. Cranial nerve checks can give powerful clues. Pupillary response and eye movements may reveal increased intracranial pressure or brainstem involvement. Facial symmetry, corneal reflexes, gag, swallowing, and tongue movement can help identify stroke risk, aspiration risk, or lower brainstem dysfunction. The key is trend recognition. A single score matters, but the direction of change matters more. Advanced cardiovascular assessment means looking beyond one blood pressure reading. Non-invasive blood pressure, MAP, pulse pressure, arterial lines, central venous pressure, cardiac output data, and waveform quality all need to be interpreted together. If an arterial waveform looks dampened, validate the setup. If non-invasive and invasive readings do not match, compare them with the patient's actual perfusion, mental status, capillary refill, skin temperature, urine output, pulses, lactate, and overall trend. Heart sounds can also matter. An S3 may suggest fluid overload or acute heart failure. An S4 can point toward decreased ventricular compliance or ischemia. A new murmur in an unstable patient may signal acute valve dysfunction or endocarditis. A pericardial friction rub can be an urgent clue to pericarditis or tamponade. Early cardiovascular compromise may show up as cool, clammy skin, delayed capillary refill, narrowing pulse pressure, new arrhythmias, decreased urine output, rising lactate, metabolic acidosis, and escalating vasopressor needs, often before dramatic hypotension appears. Respiratory compromise can evolve within minutes. Start with what you can see: symmetry and depth of chest movement, accessory muscle use, retractions, nasal flaring, ventilator synchrony, abnormal breathing patterns, and signs of fatigue. Palpate for tracheal deviation, abnormal vibrations, or subcutaneous emphysema. Then listen carefully. Diminished vesicular sounds may suggest atelectasis, effusion, or consolidation. Bronchial breath sounds in the periphery can suggest lung consolidation. Fine crackles might point toward pulmonary edema or early pneumonia. Coarse crackles may reflect secretions or fluid in larger airways. Wheezes can mean bronchospasm, secretions, obstruction, tube kinking, or airway edema. Stridor is an airway emergency. Next, connect the bedside exam with technology. SpO₂ trends, ABGs, end-tidal CO2, capnography waveform, ventilator settings, peak pressures, tidal volumes, FiO2, PEEP, and alarms. A patient can be confused with a normal SpO₂ because CO2 is rising. A ventilated patient with sudden desaturation needs rapid assessment for disconnection, obstruction, pneumothorax, equipment problems, or acute lung pathology. Expert ICU assessment is not just a set of separate system checks, it's synthesis. Sudden confusion with a new arrhythmia may reflect decreased cerebral perfusion. Increasing heart rate, rising CVP, and worsening hypoxia may point toward fluid overload, right heart strain, or worsening pulmonary disease. Fever, hypotension, confusion, oliguria, mottled skin, and elevated lactate can form an early sepsis pattern. Technology should never replace your hands-on exam, but it can strengthen your interpretation when you integrate it correctly. Ask yourself, is this acute or chronic? Is this one abnormal value or a trend? Does this finding match the patient's baseline? Are multiple systems deteriorating together? Red flags include sudden neurological change, hypotension with altered mental status, tachypnea with rising CO2, oliguria with mottled skin, new arrhythmia with chest pain, and escalating vasopressors with rising lactate. When patterns cluster, don't wait for a perfect picture. Escalate early. Assessment only helps the patient when it leads to timely action. Communicate urgent findings clearly and early. First, identify and prioritize the red flags. Then, structure your message. SBAR is a reliable tool. Situation: what is happening right now? Background: what matters about this patient? Assessment: what are you seeing and what pattern worries you? Recommendation: what do you need next? Provider at the bedside, respiratory therapy, imaging, labs, medication changes, airway support, or rapid response. After you communicate, close the loop. Confirm that the team understands the concern and the next steps. Document what you found, what you did, who you notified, and how the patient responded. In high acuity care, clear communication turns bedside vigilance into coordinated intervention. Let's do a rapid review. Question 1. Which finding is an early sign of acute neurological deterioration, a sudden change in pupil size or reactivity? Question 2. A patient has mild hypotension, rising respiratory rate, and new confusion over a short period. What pattern should you suspect? Early multi-system deterioration requiring prompt escalation. Question 3. What does an S3 heart sound suggest in a critically ill patient? Possible fluid overload or decreased ventricular compliance, often seen in heart failure or sepsis. Question 4. Loud, high-pitched breath sounds heard over peripheral lung field suggest what? Bronchial breath sounds in an abnormal location, possibly lung consolidation. Question 5. Advanced ICU assessment integrates technology, pattern recognition, and what else? Critical thinking, repeated reassessment, and clinical judgment. The big takeaway is this: advanced ICU assessment is about vigilance, pattern recognition, and timely escalation. Look closely, trend findings, compare to baseline, connect systems, communicate clearly. Your assessment can be the earliest warning system your patient has. If this helped, like, subscribe, and share it with another ICU nurse or nursing student. Stay curious, stay compassionate, stay competent. This video is for nursing education only and does not replace facility policy, provider orders, or clinical judgment at the bedside.